And today we are lucky and privileged to have Dr. Kapil Agrawal, sir. He is presently working as a additional professor with the GS Medical College at KEM Hospital, Mumbai, India. And he has got special interest in rhinoplasty and facial plastic surgery. He has developed simpler methods to achieve consistently good results in all types of Indian noses. And he has also contributed various chapters in various textbooks of rhinoplasty, like secondary aesthetic rhinoplasty, building rhinoplasty practice, allergy waste management, photography in plastic surgery, etc. He has also been invited faculty in national and international conferences and live surgical workshop and master classes. He has been the Rhinoplasty course director for the Rhinoplasty Society of India and IAPS, and have been awarded with various prestigious awards like NH Anantia Award, prestigious Pete Prize, and also he's an artist and a singer and has drawn and a painter as well. He himself draws all diagram of all his articles and chapter. So we welcome you, sir, in this online webinar, and we are looking forward for your talk on augmentation rhinoplasty.
Thank you, Manya. Thank you. Yeah. Nice introduction. Shall I share my PPT? Good evening, everyone. And I would like to thank Dr. Braser for inviting me for this talk, and giving me opportunity to present my work. I will be talking on augmentation rhinoplasty today. Augmentation rhinoplasty looks very simple one, and initially when we were actually resident, our teacher used to say that the augmentation rhinoplasty is the easiest rhinoplasty to be done or to be learned in the initial phase. But after doing so many rhinoplasties, actually I got to know that augmentation rhinoplasty, mainly in the Indian noses where the skin is very thick, sebaceous, and paradoxically the cartilages are very weak, this augmentation rhinoplasty becomes actually a difficult one, or more difficult than reduction rhinoplasties. Reduction rhinoplasty is like in mathematics, you just calculate how much you have to reduce the cartilage and you can do it. But in augmented rhinoplasty, there are so many things to learn, and you keep doing and you keep learning the things. So this is one of the typical Indian noses. You can see here. Usually they are having low dorsum, broad bridge, short length, pileated alley, thick sebaceous skin, and paradoxically weak cartilages. And most of the time when we start doing our rhinoplasties, we mainly focus on augmenting the dorsum. And if you see these noses, the face is round and the nose is very short for the face, bulbous tip, and short length. In these cases, if you go only for dorsal augmentation, the nose doesn't look proportionate. In these cases, it's actually it is done very wrongly. So the cartilage is eccentrically put. Nothing has been actually addressed in these cases. Again, in this case, only our dorsal augmentation was attempted. Nose looks very short for the face, and here the short nose with the elevated dorsum, but then nothing else is addressed here. It's better to have short depressed nose rather than having elevated short nose. So only dorsal augmentation in these noses give an appearance of a done nose. From far away, you can identify that somebody has done something to the nose. These kind of noses, mainly in the Indian noses, we need to do multi-dimensional augmentation. And the most important thing in the nose is length of the nose in proportion to the face. And then comes the tip projection. If at all the skin envelope and the lining allows you to do the dorsal augmentation after doing these two things, then you can go for this, and then it will be then ideal kind of augmentation when you are augmenting the nose in all the directions. For augmenting these noses, you need to have strong structural support, for which you need a cartilage graft which is having strength as well as supply in abundance. We have three kind of cartilages: septal cartilage having good strength, but usually it is lacking in the supply. Conchal cartilage lacks in both. Costal cartilage supplies both good strength as well as abundant supply. But it comes with the red flags or problems of graft visibility and warping. Graft visibility is mostly due to the faulty carving techniques, but the warping is a menace, and it's an inherent property of this cartilage to bend. If you search the literature, you find many tricks and techniques to deal with this menace, and whichever works best in your hand, you must use it before using this cartilage in the nose. And I initially, when I started my practice, I used to use the Gibson's technique, in which we used to use the core piece, where we feel that the forces remain either no forces or very less forces are there, but forces are there, and those forces are in the direction of the C or the shape of the cartilage. They remain there whether they are less or more. Initially, when I started my practice, you can see that this case absolutely straight nose on table, and then in few weeks time it acquires the same shape of the cartilage, because the forces are there inside whether they are less or more. And so sometimes you just cut the cartilage and they warp like a C, or sometimes like a jalebi, they become round. So I used to think that how to keep it straight, and one day I got one idea, very simple idea, that I gave the name the counterbalancing or namaste technique. It works on the principle of physics, which tells that equal and opposite forces neutralize each other. I usually harvest 6 or 7 costal cartilage. Before harvesting the cartilage, I take the anterior pericontium, the one strip of the pericontium, and save it in the saline. And then I cut them, mark them in the midline, and cut equal pieces. All pieces will be curved, reverse them, and suture them in the midline, so they become straight and strong studs. You can suture them in midline, they become straight studs. And while I'm preparing the dorsal graft, depending on the thickness of the graft and the height of the graft, again I cut in the midline, reverse them, suture them depending on the thickness, and either we can go side by side or as an stack depending on the height I need. Because sutures are in midline, so these cartilages can be carved from all sides without cutting the sutures. And to reduce the visibility of the cartilage, first you put the pericorneal graft over that, and to make it a rounded one, you can fill some small dice cartilage in between the two, so give a very nice shape to the dorsal. It looks like an implant, auto implant. This is a video.
Marking in midline, dividing into two equal pieces. Again, marked and dividing into two equal pieces. Reversed. Suturing in midline. Carving it from all sides without cutting the sutures. Covering it with pericondyal strip. Filling the dice cartilage in between the pericondium and cartilage sheet. Final shape. Marking in.
And while we are carving the graft, dorsal graft, the variable skin thickness needs to be understood. and considered while carving the dorsal graft. You see here, this is the radix area where you have procerus muscle. The thickness of the skin you can see is the highest here. And then again in this supratip area, you have thickened skin. But the God has given very nice anatomy inside. The dorsal skeleton is slanting down here and slanting down again here to adjust the skin thickness inside the nose, so we get the straight nose outside. So we just have to follow the normal accommodative anatomy to have the normal look. If we carve uniformly wide and uniformly thick dorsal cartilage, it will be giving bulging in the, just a moment. हेलो राघव, बेटा 8 बजे आना, मैं अभी मैं मीटिंग में हो जाएंगे. Uniformly thick or wide cartilage, if you use, it gives bulging in both areas, laterally as well as in the supratip area. To avoid this, you just slant your cartilage graft both sides, so it will accommodate the skin thickness inside the nose without the need of the to reduce the bulk of the skin in both the areas. And to avoid having any dead space there, you may use in few cases this subdermal stitch inside, which was described by Dr. Gairan. I come to the clinical examples. Short noses with adequate soft tissue envelope. Adequate soft tissue envelope means the envelope which you can stretch in all directions. They have that flexibility and stretchability. In these kind of cases, they have adequate skin which can be stretched to increase the height as well as length. And this thickness of the supratip area can be adjusted inside only without removing the without doing the debulking. The most important thing is the lengthening of the nose, which can be achieved by septal extension graft, then tip projection by tipplasty, and dorsal augmentation with differentially carved this dorsal cartilage, which looks like an implant. And you without doing any thinning of the nose, the skin supratip skin, you can achieve slimmer look, and the length of the nose looks proportionate to the face, so the patient looks normal. And if needed, in few cases, you can do LR reduction. Similar kind of case, short nose, depressed dorsum, bulbous tip, and you can get slimmer look with proportionately long nose. Ill-defined nose, broad bridge and LR axis, dorsal augmentation done with a differentially carved graft and tipplasty and LR reduction. You can have slimmer kind of look without doing the skin thinning. In this case also, you see that the lip looks very long here because of short length of the nose. You increase the length of the nose and face start looking normal. Come to the other kind of cases where the soft tissue envelope is short in supply, which cannot be actually expanded in all directions. This is an example of binder syndrome. This is secondary binder syndrome. Somebody has put one implant inside, and you can see here this screw is popping up. In these cases, you cannot increase the length as well as height at desired level. So somewhere we have to compromise. So whenever we have to compromise somewhere, we can compromise on the height rather than in the length of the nose. So first you concentrate on the lengthening of the nose and the tip projection. The primary binder syndrome, where the length is almost normal, but this nose is very, the height is very less. In these kind of cases, after doing so many cases and having so many problems, I came to this conclusion that something else should be used, and I came up with this idea of using tent pole or dorsocolumnar graft. So in these cases where if you go, if you open the septum and try to fix septal extension graft, the purchase where the anterior, the caudal part of the septum is a very small and low lying, so it becomes very difficult to take the sutures, and the graft will be moving. So it's better to take to use this technique instead of using septal extension graft in this. So I use this 10-pole graft technique in cases where the septum is low lying, there is paucity of cartilage, and multiple times operated nose where I or you don't want to use or to dissect the septal angle. And sometimes the patient is having a big septal perforation in either anteriorly or posteriorly. So you don't want to open those cases. In those cases, I use this one. It's very easy technique to use. They use one columnar strut and behind one support graft, which can be kept wherever you feel that lengthening of the nose is achieved, or the nasolabial angle of desired angle is achieved. We just fix with the needle first and then suture in the desired level. You can achieve a slight longer length as well as the nasolabial length of nasolabial angle of choice. You can get the projection as well as slight lengthening of the nose without touching the septum at all. In this case, this same technique has been used to give the projection of the nose as well as the length of the nose. And the height, I did not do anything, and just increase in the height in this area only. And these noses, again, this is crooked nose, but it is short. So the most important thing is to lengthen the nose. Not only you have to do the straightening on the nose, and the straightening also can be achieved after doing the septoplasty. Remove the lower part, leave a L-shaped strut there, and then to make it straight, when you put two curved cartilage beside this curved septum, and when you suture them, they become straight and they keep the septum straight. So this counterbalancing technique also can be used to make the septum straight. You can keep the nose straight for forever. I come to the secondary noses. In secondary noses, the most important examination or assessment is the quality of skin. The thickness of the skin does matter, but more important characteristics are suppleness, pliability, and elasticity. And so, utmost importance must be given to adequate preparation of the skin. So, whenever somebody comes to you for secondary surgery, first you say, look at the pliability of the skin. If the skin is prepared enough, then you can go for immediately. Otherwise, ask the patient to do massage and vigorous massage for a few months. Then again see whether you can elevate the skin, pinch the skin nicely. If you are able to pinch the skin nicely, you can go and do nice augmentation and elevation of the nose. There should not be any compromise on this aspect. The secondary nose needed lengthening as well as this treatment of this bulbous tip. In few cases, there are two actually. If you see the anatomy of the nasal skin, there are two places where you find the fat. First, above the SMAS and one below the SMAS, above the or supraperiosteal layer, where when you open that, you find the fat here in the supratip area. You take either insulin syringe or very thin needle, and when you inject the saline there, the fat becomes like a balloon, and without damaging anything, just you can remove this by with the help of the scissor. It comes like a sheet of the fat, and it becomes like a balloon. So easily, without damaging the subdermal plexus of vessel, you can remove this. And in few cases only, you need to remove only fat, no thinning of the dermis at all. and you can get very slimmer look by having differentially carved graft. And this technique can be used in any kind of secondary nose, whether it's a secondary aesthetic rhinoplasty or secondary cleft rhinoplasty. I've kept this photographs or this patient just to emphasize on the need of skin preparation. This lady came with this kind of nose. She fell down from a scooter and got this torn nose. We sutured that properly. And after suture removal, she came to me and started crying that please give me my nose back. If you see this kind of noses, you touch them, they'll be feeling like a rocky heart, and you just cannot go in and do anything. I asked her to do massage, and after 10 months, you can see how she was able to elevate the skin from all sides. And then I did the lengthening, elevation in all directions, and she got nice nose. And the scars also got settled nicely because of massage. So the importance of massage you can see here. I conclude here, the length of the nose and tip projection must be given priority in short and depressed noses. When skin envelope has limited stretchability, it's better to compromise on the height of the dorsum rather than length and tip projection. The height can be increased later on without opening the nose. You can fill it with some fat graft or something, or 2 or 3 millimeter you can increase at any time. But 2-3 millimeter, to increase at 2-3 millimeter or 5 millimeter length, you have to open the nose and do some lengthening procedure inside. So it's better to compromise on the height rather than, and then proportionate lengthening of the nose, long nose, as well as tip projection. Even slightly low dorsum looks normal, you can say, or it looks better than having short elevated nose. And thickness of the supratip skin cannot be reduced at will. We all know that, otherwise you may end up in some problem. You may get necrosis of that area or irregularity of that area. So slimmer nose with acceptable tip is possible even in the thickest of the skin in that area, by using that differentially carved graft to accommodate the thickness of the skin inside the nose. Skin thickness can be adjusted by differentially carved graft following the natural anatomy. And secondly, nose, I told you that the most important thing is to do the massage and get prepared skin before opening that. These are my articles. Thank you.